Today we are going to start the pharmacology of the CNS. Pharmacology of the CNS is no fun, I know that. It's not an easy subject. It's not super difficult in the same time, but however, it requires really solid memorization. This is why I highly advise you to print this page and to print this page. Print these pages, put it in the bathroom, put it in some place that you will always see at. Okay, so sound checking. Can you hear me, everybody? Excellent, good, let's do this. So over here, first of all, they are telling us about a partial seizure and a tonic-clonic seizure, absence seizure, and status epilepticus. I would like you to understand what do they mean. So the seizures are subdivided into a partial seizure and into a basically a generalized seizure. A focal seizure is a seizure that occurs in one portion of your brain, and the word seizure means basically it's an electrical storm inside of your brain. So this electrical activity will be mostly in one focus. And do you know which lobe of the brain is the most likely to get the focal seizures? Which lobe of the brain is most likely to get it? It's actually going to be the temporal lobe. Yes, excellent, good. So generalized seizure, basically, so I was asking, in focal seizure, most likely which lobe will be affected, and the answer is temporal lobe. Generalized seizure, however, it's all over the place. They affect the whole brain, not one area between them. By the way, what connects the right and the left hemisphere of your brain? What do we call this structure that connects both right and left hemisphere? Corpus callosum. Yes, so this corpus callosum, its function is to pass information and electrical activity from right to left. Let's say that the person has generalized seizure. Will the seizure be in hemisphere number 1 or number 2 or both of them? Both of them. Why? Because the electricity can pass freely through here. Wait a second. That sounds interesting. What happens if I just cut this guy? Can the patient have generalized seizure if you cut this? Exactly. No, he cannot. That's one of the most invasive treatment for generalized seizure that cannot be treated by medication. Basically, if the seizure cannot be treated with medication at all, the electricity will be wanting to jump to the other side, but it will be halted, right? So the seizure will stop immediately. So corpus callosum can be utilized, corpus callosum cutting can be utilized as a treatment for this generalized seizure. A tonic-clonic seizure, remember, first of all, the patient becomes stiff and they fall down, right? So they just lay down and like, they don't move, unconscious. And then they start shaking. That's the clonic phase. So the tonic phase is the fall, and the clonic phase is the dancing movement, right? Okay, so tonic-clonic seizure. You need to be careful about people who get a seizure. Why? Because they might bite their tongue, they can urinate on themselves, and they can hurt themselves. So if a person in front of you has a seizure, what should you do? Should you grab his head to prevent him from biting his tongue? No, you should not. Here is the idea. You stabilize his head and that's it. Don't try to put your fingers inside of his mouth. Why? He is totally unconscious. Guys, as a human beings, you can get your own finger, put it in your mouth, and bite it like a carrot. Literally. If you try this now, you will not do it because your brain will not allow you to do it. Okay? But in the patient who have a seizure, he's not mentally there. So when you put your fingers inside of his mouth, there is big chance he will be like, delicious. So yeah, don't put any fingers anywhere near his mouth. He's going to bite you. However, you can push against his masseter muscle to open his mouth if he has respiratory insufficiency. Okay, so the absence seizure. It's that kid in school who just sit and stare in the blank. And the teacher tells him, "What's up?" And he's just staring. "What's up? Are you alive?" And suddenly he snaps out of it and he's like, "Huh?" And this sound that I just made, the patient actually do this sound, it's automatism, which means that he started playing with his oral cavity, something like this. Yeah, it's this annoying sound. So, and start like licking his lips and stuff like that. When he wakes up from the seizure, however, he does not have a postictal state. A postictal state is a state of confusion that occurs after a seizure. Status epilepticus is a seizure that lasts more than 5 minutes. Okay? Okay, so what's the big deal? What should I do if it lasts more than 5 minutes? Benzodiazepines you should give. What if that will not stop it? Give phenotine. What if that will not stop it? Give benzodiazepines again. What if that will not stop it? Give phenotine again. What if that will not stop it? Generalized anesthesia. I repeat, status epilepticus is a seizure that is not stopping regardless of like more than 5 minutes. 5 minutes, it's not stopping. So what to do? Benzodiazepines not working. What to do? Phenotine not working. What to do? Benzodiazepines not working. What to do? Phenotine again. What to do? Last thing, generalized anesthesia, because when seizures stay for a really long time, they lead to an anatomical damage of the brain structure, which can lead to an irreversible damage and the shrinking of the brain. So you must halt the seizure in any way possible. So status epilepticus, you can use benzos for it. They write here. First line for acute and first line for recurrent seizures prophylaxis. Okay. It has a GABAergic action. Remember, the GABA neurotransmitter is inhibitory, so you will have sedation. Sadly, sometimes you will have tolerance, meaning if you keep using it, it will stop working. And dependence. Why? Benzos make you happy. It relieves your anxiety, make you euphoric a little bit, so people might abuse them and become dependent on them. And respiratory depression. So this is actually serious because this could be a reason of death. However, the benzodiazepines tend to be much more milder than the phenobarbital. You can use phenobarbital, but nobody likes it. It has really bad reputation. Why the bad reputation? Because it is highly addictive. Okay? Benzos is addictive, but not as much as phenobarbital. So note, also for eclampsia seizure, the first line will be in that case is magnesium sulfate. So regarding the eclampsia, what is eclampsia? We'll study this in reproductive. Basically, ladies who have eclampsia are pregnant, more than 20 weeks of gestation, and they have really high blood pressure, yes, really high blood pressure, but remember, more than 20 weeks of gestation, and that we call preeclampsia. For the preeclampsia to become eclampsia, you need a seizure. Okay? So if you have a preeclampsia with seizure, that's eclampsia. Carbamazepine, oh, they love this one. So carbamazepine is the first line treatment for trigeminal neuralgia. Remember this guy? The patient feels like he's getting stabbed on his face, together with burning sensation. It sucks big time. It can be utilized for partial seizure, but to be real with you, that's not why we use it for. We like to use it for trigeminal neuralgia. So it blocks the sodium channels, and you are like, how the hell am I going to memorize all of these? Don't worry. This picture will help you to memorize all of the mechanisms of action. So we spoke about the benzo. You can see how it's working at the GABAergic channel, basically, okay? And we spoke about the carbamazepine. You can see how it's working at the sodium channel. So just to print this, put it in your bathroom. Carbamazepine can lead to diplopia because it leads to an ophthalmoplegia and ataxia as well. And the most they like the side effects. It can lead to agranulocytosis and aplastic anemia. In case of aplastic anemia, you'll have loss of all types of cells, not only RBCs. Liver toxicity can occur, and teratogenesis, meaning the patient, if she takes it when she's pregnant, she has high risk of getting a child with defects, including a cleft lip and palate and spina bifida. It can induce the cytochrome B450, which can lead to the drugs becoming metabolized much more faster, which decreases their activity on the long term. Something that is high yield, these two. So it can lead to SIADH, which is severe inappropriate antidiuretic hormone release. Somebody really quick, tell me what will happen to the osmolality of the blood in this case. osmolality of the blood in case of SIADH. So the osmolality of the blood will be so down. Why? Because basically you are reabsorbing plenty of water, right? So the amount of water compared to the amount of sodium will be high. Somebody said hyponatremia, you are right. Because of that, like the amount of osmoles is much less than the water inside of the body, which lead to the hypoosmolality of the blood. What about in the urine? What do you think? We are reabsorbing plenty of water from the urine. So the urine will be, come on, just try the word. Hypo or hyper? The urine, SIADH. Hyper, more concentrated, absolutely. So also SGS can happen, which is a Stevens-Johnson syndrome. Let's take a look at people with the Stevens-Johnson syndrome. Stevens-Johnson syndrome. Okay, Stevens-Johnson syndrome. They have this skin symptoms that really sucks. If you can see here, it looks, oh my God, it looks bad. Is it reversible? I mean, if the patient is properly treated, will it leave scars or no? Look at this poor guy. Will it leave any scars? No scar. Absolutely correct. No scars will be left because it does not affect the striatum basale. However, it sucks, okay? And it affects the oral cavity. Just keep this in mind. So if the patient survives it, he will not have a scar, but it itself is like really bad. Yep. Okay, the next thing. The next thing is ethosuximide. Oh yeah, this is high yield. So some of these drugs are quite high yield, some of them are so-so, you know? Like topiramide is so-so, lamotrigine, they care about one thing in it. Levetiracetam, never saw a question about it. But ethosuximide, I always saw it. Benzo, I always saw it. So ethosuximide, it is utilized only for absence seizure. Remember, the absence seizure was this type of seizure that the patient is looking at you and he's like, He's like confused, you know? And he does not have consciousness, the patient, most common in people who are in children in school, basically. And what else? Yes, when you give this ethosuximide, it's giving to prevent this from happening in the future, okay? Nice. So let's take a look. The next thing is as follows. Let's see. Ethosuximide, it blocks the T-type calcium channels, and they are highly specific by telling you the T-type. Why? Because the T stands for thalamus, T for thalamus. So it's not the same one as in the heart. So let's take a look. Ethosuximide, a calcium channel blocker, and it can lead to the following symptoms. Basically, alphabetically, E, F, G, H, I, J. Yes, so the I type in the heart, it's not the same one. Yes. So ethosuximide can lead to fatigue, GI distress, and headache. All of this is bullshit. Nobody will ask you about this. But what they will ask you about is the itching. It can lead to hypersensitivity reaction and, well, basically urticaria and Stevens-Johnson syndrome as well. Do not forget about the fact that carbamazepine also led to Stevens-Johnson syndrome, okay? So the next one is as for, oh, I like this one. It sucks to have a silent seizure. So ethosuximide. So next we have gabapentin. It can be used for the focal seizures as well. It's a low yield medication. However, it has GABA in the name, gabapentin. So primarily inhibits the high voltage activated calcium channels in the brain, designed as a GABA analog. So if you take a look here, just a moment, this is carbamazepine. We just discussed that. And we discussed also the ethosuximide, which is a calcium channel inhibitor. And now the gabapentin, right? So the gabapentin also can inhibit the calcium channels, as you can see. Okay, so the next drug is, so basically when you study these, keep going up and down, up and down, up and down. This way you get them. So gabapentin is relaxing. It's a GABA analog as well. So it leads to sedation and ataxia. Basically, you look drunk. So also used for peripheral neuropathy and post-herpetic neuralgia. For example, somebody who had shingles and now they went away. They leave the pain behind. The best medication to give for patient with any type of neurological pain is gabapentin. If that is not an option, you would choose what? Tricyclic antidepressant, like amitriptyline, okay? So gabapentin for neurological pain. If it's not working, TCAs. Guys, I have a question. If a patient had an amputation of his leg, can he still feel the pain in his leg? It sucks. It's called phantom phenomena. They do feel the pain in their legs, even when it does not exist. The patient will be like, and it's common, by the way. The patient will be like, doctor, my leg is hurting me. And you are looking at it and there is no leg. And you are like, are you fucking with me? And they're like, no, I feel an actual pain. And he does. It's completely correct. He does feel the pain, but it is from his brain. It's not psychological. It's actual pain. So how to stop that? Gabapentin or a tricyclic antidepressant. Don't tell him it's psychological. Don't be that. Ask doctor. It's a real justified pain that need to be managed. And you should take care of your patient and treat it for him. Okay, the next one. Don't give morphine, don't give NSAIDs, that will do nothing. They need something that work on the neurotransmitter, so gabapentin and amitriptyline. Even the strongest morphine will not help him. And this is commonly mistaken in the hospitals. The patient have this phantom pain and the doctors be like, okay, if NSAIDs are not working, I need to step it up. They give him the morphine, he feels high, but he still feels the pain. You did nothing. So you have to give gabapentin or amitriptyline, which is a TCA, tricyclic antidepressant. Lamotrigine is the next one. Oh yeah, they love this one big time because of the SGS. I know that the other medication also lead to Stevens-Johnson syndrome, but they specifically like it in lamotrigine because there is nothing else interesting in it. So lamotrigine can treat a lot of seizures. I want you to notice something. Any medication that has affect more than 3 types of seizure is considered to be a wide spectrum type of medication. Okay, so let's take a look. Lamotrigine blocks the voltage-gated sodium channels and inhibit the release of glutamate. Okay, so SGS must be titrated slowly. So we have hemophagocytic lymphohistiocytosis can occur. What is this thing? Hemophagocytic. Hemo means blood, phago means eating, cytic means cell. So in this disease, the cells, the eater cells like neutrophil and macrophages will start to eat other blood cells. Exactly, that's what happens. Basically, your phagocytes, including your neutrophils and macrophages, they will start to eat your normal cells, your normal body cells. And when it's like cannibalism, they start to eat it. And when this occurs, the peripheral smear will look like this. Let's take a look at it. So you can appreciate in this picture, for example, there is a phagocyte that has multiple neutrophil in it. And this phagocyte has a monocyte in it and plenty of RBCs in it. And this phagocyte has 3 lymphocytes in it. So you can appreciate how one cell is eating other cells. That is known as lymphohistiocytosis or also hemophagocytic lymphohistiocytosis. Okay, so the name is a mouth twist, but you get used to it. Okay, really quick. Kidney-shaped mononucleus. One nucleus that is kidney-shaped. What is the cell? Come on, kidney shape. No, it's not basophiles. Come on, it has kidney shape. Kidney shape, clear clear cytoplasm. You need to think more about monocyte. Okay. So what about boom, boom, boom. Okay, later I will be teasing you about the other types of cells. Okie dokie. Let me just ask you about this one, but it's pixelated. Come on. What cell is this one? No, come on. It's not an RBC. This is an RBC. This is an RBC. This is not an RBC. This is a lymphocyte. Yes, good. What about this one with kidney-shaped stuff? Monocyte. Yes. Okay, good. And what about plenty of garbage? This is a typical lymphocyte. You did not learn about this yet, so don't worry about them. Okay, good enough. So next we have the following. Boom, 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 boom. Okay, because this drug can lead to this hemophagocytic lymphohistiocytosis, and this is a really serious condition that can kill the patient. It has this black box warning. What is a black box warning? If you take an actual medication like lamotrigine, it will have on it written inside of a black box, literally, that warning, blah, 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 blah. Okay, so on the medication there will be a black box indicating that this medication can lead to some serious problem. That's what's up with it. Okay, so the next one is going to be levetiracetam. So it's less wide spectrum. It's a broad but not wide spectrum, meaning that it can work both in the partial and the tonic-clonic seizure. However, it does not work in the absence. Okay, so levetiracetam can be used, and it works at the SV2A receptor blocker. Previously, this channel was completely neglected. Nobody cared about it. Never anybody asked a question about it. But during the recent year, I've seen 2 or 3 questions about it. So I advise you that you should actually memorize it now. So SV2A receptor blocker may modulate GABA and glutamate release. Both of them are inhibitory and inhibit the calcium channel as well. So if we come here, this is the levetiracetam. As you can see, it can block the calcium release, because it will block the release of calcium from the presynaptic cleft. No release, no depolarization, no action potential, no seizure. Okay, so good. And lamotrigine, you can see how it can work at the sodium channel. So the next one is going to be the symptoms. It can lead to neuropsychiatric symptoms, personality changes, for example, and fatigue, drowsiness, and headache. Okay, so the next one is going to be, oh, I forgot about one. It can lead to nightmares as well, guys. By the way, can somebody tell me nightmares occur at which phase of the cell cycle? Nightmares. What about night terrors? Well, I know it's non-REM, but exactly at which area of the... Is it N1, N2, N3? N3, absolutely. Regarding glutamate, it is actually excitatory. You are right. Glutamine with an INE is inhibitory, but glutamate with an ATE is excitatory. You are correct. So the next one is going to be phenobarbital. It's exactly like the benzos. I mean, it's more broad spectrum, but still, most people use benzos for the stuff that phenobarbital used to work at. We don't use phenobarbital as often, and maybe if you will order it from the pharmacy, they are going to sue you, because it's really difficult to find and nobody uses it because it's highly addictive. Okay, increased GABA action by one mechanism that you will learn later, how it's different from the benzos. Basically, benzos help the chloride channel, which is the GABA channel, to keep have more frequency of opening, but the phenobarbital increases the duration in which the chloride channel is open. Don't worry a lot about it. We will speak about it today. So sedation, tolerance, dependence, and induction of the cytochrome B450, and also cardiorespiratory depression. First line in the neonates, because it does not lead to affection of their growth, but it leads to dependence. Phenytoin and phosphenotiene. Remember, somebody with a status epilepticus. We used first benzo, does not work. Phosphenotiene does not work. Benzos does not work. Phosphenotiene does not work. Generalized anesthesia to halt the status epilepticus. So it blocks the sodium channel. It has a zero order kinetic. Remember, only 3 medication had zero order kinetic. It was the B like this. That was basically this guy, the phenytoin, E for ethanol, and A for aspirin. Only these 3 medication have zero order kinetic. So phenytoin, it's cytochrome B450 induction. Pseudolymphoma, so basically it can lead to a painless enlargement of your lymph node, but it's not a lymphoma, but just scary as hell. Hirsutism, a lot of hair all over your body, and especially in ladies, and enlarged gums, gingival hyperplasia, basically. Do you remember any other medication that can also lead to gingival hyperplasia? This is going to be calcium channel blocker and also calcineurin inhibitor. Okay, the patient can have nystagmus as well, which is a shaking eye movement. Okay, so on the skin, the patient can have this yellow-brown pigmentation of his skin, and also it's teratogenic, leading to something known as the fetal hydantoin syndrome. This will be super important in reproductive. It occurs only because of phenotene, and this patient basically, just a momento. I want to find a picture of nails. Okay, good enough. So basically, they will have microcephaly, cleft lip or palate, and the most important thing, hypoplasia of the nails. Yes, this is fetal hydantoin syndrome. Super important. Okay, so osteopnea and inhibits the folate absorption, leading to a B9 deficiency and a macrocytic megaloblastic anemia. Neuropathy can be occurring in this patient, which will make you sometimes misunderstand it to B12 deficiency. It's not. It's phenotene, basically toxicity. Rare effects can be SGS or a DRESS syndrome or a drug-induced lupus. Drug-induced lupus can also occur with which other medication? Can somebody tell me other medication that can lead to a drug-induced lupus? Just one more. Okay, isoniazid. What else? Hydralazine. Yes. Okay, the next one is toxicity can lead to diplopia, ataxia, and sedation. Phenotene is used a lot. Topiramate. Topiramate is also a blocker of the sodium channel. So this guy is going to block the sodium channel and increases the GABA action. Okay, as you can see here, it increases the GABA action. So that will lead to GABA action. Sounds everything is going to be slow. So sedation, slow cognition, kidney stones. Guys, even when you drink alcohol, what makes you a little bit calm? It's actually the increase in the GABAergic action caused by the alcohol. So slow cognition, kidney stones, skinny, weight loss basically because of the topiramate, and a slight threatened glaucoma and speech. So word finding difficulties. It's like this Broca type of thing. So it's also associated, it's also used for migraine prophylaxis. Does anybody remember, for a cluster headache, how do you abort the cluster headache? How do you stop it immediately right now, at this second? Cluster headache. Come on, how to stop a cluster headache? Nope, actually we give oxygen. Oxygen can halt and stop cluster headache. If you go back to that picture, you can see that supplementation of 100% oxygen can halt the headache, okay? So it's a really bad type of headache, by the way, the cluster headache. So the next thing here we have is valproate, wide spectrum of action. So sodium channel inactivation and GABA, increased GABA concentration by inhibiting GABA transaminase, which breaks down the GABA. So valproate, okay, so it can lead to vomiting, alopecia, liver damage, like it because it's hepatotoxic basically, pancreatitis, B450 inhibitor, rash, obesity, tremor, teratogenicity, neural tube defect because of B9 deficiency, and epigastric pain. A list of side effects. Do you think this drug is commonly used? Really long side effects. Well, here's the idea. It's so commonly used. Like, neurologists tend to consider it the #1 drug. Do you know why? Because of this. It works on everything. Okay? So every single neurologist is like, okay, let me start you on valproate initially just to stop the seizure, and then we will titrate this down and start you to a more specific medication, for example, okay? But initially, The way to deal with seizure is to start with valproate, and then you go to a more specific medication that has less side effects, okay? So it's also used to myoclonic seizure, bipolar disorder, and migraine prophylaxis. Bipolar is super important because it's more of a psychiatric type of illness, but this anti-epileptic works against it. So in bipolar disorder, I hope you remember they have phases of being manic, and then they will become depressed again, and then manic, and then depressed, and then manic, and then depressed. It's annoying. Anyway, you can stop it with lithium or valproate in people with contraindication to lithium, like people with thyroid problem. The last medication is vigabatrin. It is increasing the GABA, irreversible GABA transaminase inhibitor. This one sucks. Why? Because vigabatrin is going to lead to vision loss, VI for vision loss, permanent visual loss, which means that after you stop the medication, the vision will still be gone big time. It is a rare side effects, 1 over 50,000, but nobody can assure you that you will be the one or not. That's why it has the black box like warning. So if you take it, it's a new. So the sodium channel blocker, we have here the carbamazepine, phosphonidine, lamotrigine, phenytoin, topiramate, valproate. All of them block the sodium channel. If you block the sodium channel, no depolarization will occur, no glutamate release, no glutamate release, no depolarization of the postsynaptic terminal, no action potential, no seizure. Okay. The other way the medication work is the succinimide and gabapentin, blocks the calcium channel, no release of the calcium, no binding to the lambda, no binding to the lambda, no action potential, no seizure. The other way that drugs work, like levetiracetam, it works on the SV2 receptor, which prevent the vesicle from releasing its neurotransmitter, so there will be no activation of the postsynaptic cleft and no seizures. The next one is going to be here. So this is the first synapse. This is the second synapse binding to the disconnection. Basically, this guy is an inhibitor. He releases GABA. So what happens? The first way for it to work is we have this GABA transaminase inhibitor. GABA transaminase help to break down the GABA. You don't want this to happen. You want to increase the GABA in the neurotransmitter, so it will work on this postsynaptic terminal to inhibit it. So GABA transaminase inhibitor will break this down. So what will happen to the GABA? It will increase in the amount. When it increases in the amount, it will eventually go out and relaxes the postsynaptic cleft, meaning no seizure. The other way is to inhibit the GABA reuptake. So that will be with the tiagabine. So when you inhibit that guy, amount of GABA increases here, inhibiting this guy. I have to say, I don't even remember this name. So some of these medications are not high yield, some of them are super high yield. Benzos, topiramate, phenobarbital, and alcohol can work at the chloride channel, which increases, they are GABA agonist, which as I told you, GABA bound to a chloride channel. So this chloride channel is going to work passing in a lot of chloride, which will prevent the depolarization from occurring. So no action potential occur. So the patient will be calm. Okay, guys. So I will see you in 10 minutes. See you in 10. They increase the duration of a chloride channel opening, thus decrease the neuron firing. Why? Because the chloride, when it goes in, and if we speak, this is the action potential thing. So for the sake of getting action potential, you should become more positive, right? You should become more positive, and here it's negative. So it's here, and you're supposed to get more positive to get action potential. But the chloride is negatively charged, so it will not allow this to happen. And instead, when the chloride enter, it's going to inhibit the postsynaptic cleft even more, preventing the depolarization because of the entry of the negatively charged chloride. That leads to decreased neuron firing, and yeah, barbiturate, durate, increase the duration of the opening of the channel. Clinical use, sedative for anxiety, seizures, insomnia, and induction of anesthesia. Okay, I will stop to this one. Why? Because all of these sounds kind of like, yeah, they are bad, okay, but they are not going to kill you that quick. And all of these, we can give them as a like phenobarbital tablets, okay? Highly addictive. We stop to do this these days. We don't do it. There is so many other medication we can give. Induction for anesthesia, so it's just the beginning of putting the patient to sleep. Remember, anesthesia, for all of you anesthesiologists out there, we have two things. We have the induction and the maintenance. To induce anesthesia, you need a medication that will go straight to the brain, work really, really quick, and basically knock the patient out as fast as possible. But the maintenance, you need the medication that will work slowly. Okay? So the one that works really quick is thiopental. However, it works slowly and it stops working quickly as well. So it's just for the induction of the anesthesia, not for the maintenance. Adverse effect, we have a good list here. Respiratory and CVS depression can be fatal. CNS depression, well, can be exacerbated by alcohol use, so please don't do alcohol while on it. Remember, alcohol also stimulates the GABA. Dependence, drug interaction, because it induces the cytochrome B450, and an overdose treatment is nothing. That's the problem here. One of the main problems of barbiturate, highly dependent, high dependency, addiction, tolerance, no antidote. Okay? So if you have an overdose, the treatment is just supportive. You tell the patient, you can do it. I'm kidding. You don't tell him he can do it. He cannot. He needs the respiratory and the blood pressure support until the drug just clear out from his body. It's contraindicated in cases of porphyria because it can induce the cytochrome B450, which is basically going to induce the symptoms. So, benzos. So we have zibam, zulam, zibam. So, diazepam, lorazepam, tirazolam, zibam, zulam, Ziboxide. I know this one is weird, and he will be important in psychiatry. This guy, I will speak about him again in psychiatry. So all of these are kind of like, but this one is pretty high yield. Chlordiazepoxide, because it's also used in psychiatry, and alprazolam. In the clinic, the one that is most commonly used is lorazepam. Okay, so the mechanism is facilitation of the GABA action by increasing the frequency of a chloride channel opening. So it's not the duration, it's the frequency. They decrease the REM sleep. Most have a long half-lives and an active metabolite. Exception is the atom. So these have a shorter half-life. Okay, like alprazolam, tirazolam, oxazolam, and midazolam. They are short-acting. Any medication that is short-acting have high addictive potential. What about opioid? Yes, also opioid. If you have an opioid that is short-acting, it also have a high addictive potential. The longer the action of a medication, the less chance of addiction, okay? Because here is the trick. Basically, if we speak about a short-acting, it will function like this. Here is the efficacy. It will go like this, boom, okay? But if we speak about a medication that is long-acting, it will be like this. Boom. Okay, so this surge of feeling like it's nice, that's what it creates the addiction. It's the feeling fantastic type of thing. So clinical use can be used for anxiety, panic disorder, spasticity, status epilepticus. For that you can use the benzos, as we spoke about previously. For status epilepticus, it's a seizure that lasts more than 5 minutes basically. And eclampsia, which is basically pre-eclampsia plus seizure. Detoxification, like alcohol withdrawal. Somebody who's having alcohol withdrawal, he can get hallucination even. It can be really bad if he is not used, like if he used to the ethanol so long. So you need to taper it down for him, and at the same time give him some benzos until it clears out from his body, and then you can taper down the benzos as well. Long-acting chlordiazepoxide and diazepam are preferred for this situation. I mean the alcohol withdrawal. Night terrors can be treated with this guy because it decreases the N3 sleep. It decreases the N3 sleep, meaning it will save you from night terrors. Remember, well, that's a good one. Remember, in night terrors, do we remember? No, we don't. Night terrors, you don't remember. Nightmares, you remember. Okay. So general anesthetic, anamnestic and muscle relaxation. This is serious because this is the rape medication. So maybe you heard about this in the news, like some guy offering a girl a drink. She drinks the drink, she get a blackout, and she wakes up the second day and she was raped. Yes, so the rape drug. Okay, so anyone know which one is the rape drug, guys? Oh my God, this sounds scary. Speaking about rape, it's midazolam, guys. It's midazolam. It creates a knockout type of situation in which the patient will just and why it's the rape drug? Because it's short acting. It acts quickly, knock you out. You go to sleep really quick, and then you woke up and you forgot everything that happened. Anamnestic. Okay? When I say it knocked it out, it does not mean you went to sleep. Okay? You are just like relaxed, totally relaxed. Okay? But you will not remember what happened. So muscle relaxation and amnesia. Okay, do we use it as doctors? We do, come on. Where the hell they get it from? So midazolam, for whom you would like to use such medication? For somebody who's getting like a procedure, okay? That he wanna do really, really quick, but he does not wanna feel how horrible it is. I remember a friend of mine, he wanted to get a colonoscopy, and he had to do it because he has a family history of familial adenomatosis bullosa, and they wanted to do a colonoscopy. So like he was so scared and so anxious of this. I told him, would you like me to speak with the doctor? He gave me something to chill. And he was like, yeah. So I spoke with the doctor, and the doctor was super cool. He suggested midazolam. And I told my friend, it's the rape drug. Are you interested? He was like, yeah. So we gave him midazolam. It knocked him out. He did not feel a thing. He did not remember a thing. But during the procedure, I was there. He kept cursing at everybody, at me, at the doctor, at himself, at his family. Well, his family was not there, but he was cursing at everybody. After the procedure finished and the midazolam has like faded away, we told the man, are you alright? You threatened to kill all of us. I was like, really? I did? I was like, okay, good thing to know that you don't know about it. So basically, person forgets everything that happened after the medication. Really good stuff. Lorazepam, oxazepam, temazepam can be used for those with liver disease who drink a lot. Okay? So why? Because it has minimal first pass metabolism. The first pass metabolism, do you remember in which organ it happened? First pass metabolism. It was the first pass metabolism occurred normally in the liver. So you needed a medication that does not go through the liver, because in cases of liver disease, like lorazepam, oxazepam, and temazepam. So the adverse effects include dependence, addictive CNS depression effect with an alcohol and barbiturate. All bind to the GABA receptor. Less risk of respiratory depression and coma than barbiturate in this case. Okay, so there is less risk of this medication killing you than barbiturate. Also less dependence. Still, it can lead to dependence, but less likely. It treat overdose. Oh, so you can treat the overdose. It's more safe. With flumazenil, which is a competitive antagonist for the GABA benzodiazepine receptor. So basically, to prevent the function of the benzos. It can precipitate seizures by causing an acute benzo withdrawal. Guys, when you start a benzo for somebody, don't just stop it right away. That's a bad idea. If the patient has seizure, it's going to be even worse. Okay? So you need to taper it down, basically. Any of these medication, you need to taper it down. Okay? So let's take a look at the next thing. Let's see. Insomnia therapy. How to deal with insomnia. The insomnia, there is multiple ways to deal with it. Starting with non-benzo hypnotics. Well, that's what you should start with. Why? Because you, as a GB, as a internal medicine, as this specialty, you are allowed to prescribe these without a lot of control. But if we speak about this medication, you are still allowed to prescribe benzo, but you are not allowed to prescribe barbiturate. And when you prescribe the benzos, you will be asked about it if you prescribe it correct. But this one, there is less control over it, basically. Why? Because less dependence. It almost does not have any dependency. Non-benzohypnotics examples is the Z's drug. So remember in the cartoons, they used to put somebody and over his head, what they put? Zzz. What Z mean? Means he's sleeping, right? So example, zolpidem, zaleplon, and isobuclone. So it acts via the BZ1 subtype of the GABA receptor. So it's not the exact receptor as the benzos. That's the idea. So the patient will have ataxia, headaches, confusion, and cause only modest day after psychomotor depression and a few amnestic effect. So here is the idea here. Still, all of this stuff that it can cause, they will be occurring at what time of the day? When you are laying in the bed. So if you are laying in the bed, most of these symptoms you will not be caring too much about because you are already trying to put yourself to sleep. So this is put you to sleep in short duration due to rapid metabolism by the liver enzyme. However, this does not mean they knock you out. This is not what I said. They calm you down, okay? So effects reversed by flumazenil like benzos, and they have less dependency risk and decrease the sleep cycle disturbances. While the benzos, remember, they were really bad. They decreased the N3, which is the relaxing portion of the sleep, right? The benzos. So the next medication is known as civorexant, which is an orexin receptor antagonist. Hypocretin is the same as saying orexin. What is this orexin? What is this hypocretin? We don't get it. Let's try to get it. Well, orexin or hypocretin are a substance that allow your circadian cycle to sleep, and you are actually able to calculate this substance inside of your cerebral spinal fluid. In case if it was low in your cerebral spinal fluid, that means you have, what do you call this disease? Narcolepsy you have, okay? So that's when the orexin is low inside of the CSF. However, they discovered, they were like, okay, so in narcolepsy it's decreased. What if we decrease it ourselves? The patient will become more sleepy. Exactly. So they give an inhibitor called civorexant, which lead to CNS depression, basically make you sleepy. And that's the point. That's why you give it. You want a patient to be sleepy. Headache and abnormal sleep-related activities. What do I mean by that? Guys, they start to sleepwalk. However, the patient with narcolepsy, they already have a decreased orexin. So it's not a good idea to give it to them because it's going to decrease even more, exacerbating the symptom of narcolepsy. If you don't know what is narcolepsy, it's all right. We'll speak about it in psychiatry. It's basically when you wake up in the morning, you feel really tired, you start your day, you feel really tired, you go to sleep, you feel really tired. And when you go to sleep, you wake up in the middle of the night and you cannot go to sleep. And even if you wake up, you will not be fully alert. You stay in your bed for hours and hours. You cannot sleep. Next day, you are tired. Speak more about it in psychiatry. Combination with a strong inhibitor of the cytochrome 3A4 doesn't really matter. This is just a subtype of the cytochrome B450. Okay? Not recommended for patient with liver disease because of the first pass through the liver. Limited risk of dependency, that's good. Okay, basically romilation, which is basically a melatonin receptor agonist. Does anybody remember which organ in our body produces melatonin? Which organ produces melatonin? Correct, the pineal gland. The pineal gland, yes. And if the pineal gland gets super big, let's revise some neuroanatomy. If it becomes super big, which cranial nerve is going to compress? Okay, the cranial nerve that is going to be compressed by pinealioma is going to be cranial nerve number 4 because it's going to push the midbrain posteriorly, guys. Okay, for the one person who said 4, you are correct. Okay, good. So, because remember, if this is the midbrain, the trochlear nerve or the cranial nerve number 4 originate posteriorly, while cranial nerve number 3 originate anteriorly. And the pineal gland is just right here. So when it enlarges, it's going to push it, right? So melatonin receptor agonist binds to the melatonin 1 and 2 receptor in the suprachiasmatic nucleus in the hypothalamus, which make you sleepy. Basically, it changes your circadian cycle to make you sleepy right now. Make you dizzy, fatigued, and there is no risk of dependency. Old ladies love this. It actually works, and yeah, not a lot of side effects. So not bad medication. Triptan, sumatriptan. Sumatriptan is a serotonin 1B1D agonist, and it can lead to inhibition of the trigeminal nerve activation and prevent the vasoactive peptide release. Interesting. So no trigeminal activation, no vasoactive peptide release, and induces vasoconstriction. Why are you telling me that? Well, it was told that the cause of migraine is the following. One, I will tell you the two theories and why this medication works. They said that migraine is because of a massive vasodilatation. Let's see, this is the normal, and this is after vasodilatation. Massive vasodilatation of the vessels upon entering the brain. So when the vasodilatation happens, the meninges surrounding the brain is going to be stretched, leading to the pain. That was the first theory of migraine. So it's because the vessels are super big and they are pushing the basically the dura mater, leading to the pain. So this medication induces vasoconstriction, which prevent that. That's the first theory. The second theory, they said that the trigeminal nerve make a vasoactive peptide that is leading to local inflammatory reaction, local inflammation, that leads to the pain. So here they are telling you that it inhibits the trigeminal nerve and prevent the vasoactive peptide release, which means that the two theories, it's not like ideal, but this is just a theory. And the two theories, this is used for treatment. So clinical use for an acute migraine, cluster headache as well, for acute cluster headache, of course. In addition to the triptans, what other medication can you give for an acute cluster headache? Come on. O2, absolutely, yes. Adverse effect, coronary vasospasm, so it's contraindicated in coronary artery disease or Prinzmetal angina, vasospastic angina. Mild paresthesia, which is improper sensation of the extremity, and serotonin syndrome. Why? Because it's a serotonin agonist, okay? So be careful of using it with another serotoninergic medication. Okay, so the next thing we are going to speak about is going to be the Parkinson medication. Oh yeah, Parkinson. Guys, what is the main problem in Parkinson disease? Is it high dopamine or low dopamine? Low dopamine, absolutely low dopamine. In which disease we have high dopamine? Give me two diseases and win a cracker. I'm kidding, there is no cracker. But which disease have a high dopamine? Mania, that's good. Schizophrenia. And wait for it. This guy. I'm kidding. Well, basically psychopathy. So when we say somebody is a psychopath, what does that even mean? It's a person who does not have any emotion, zero emotion. But at the same time, he have this excitement only when he hears people in front of him. So it's people that are chemically messed up big time. Their frontal lobe, the one that is responsible for the behavior, has been noticed to have a lot of dopaminergic activity. So psychopaths have a lot of dopamine in their brain. Now the question, are they smart or stupid psychopaths? Think about Putin. Smart, super smart. Do they have any emotion? Not really. Can they fake it? Yes, they are masters in faking the emotion. They are masters in faking the emotions. They teach themselves basically how to fake the emotion. Well, how does somebody know that he's going to become a psychopath when he become older? Well, in childhood, he should start to have conduct disorder. What is conduct disorder? It's that child who bring little cats and kill them, or kill birds and stuff like that. He grows older in life to choose one of two paths. The first path is to become antisocial, okay? Antisocial. And the second path he can decide is just to become what? If not antisocial, is to become a psychopath, okay? Yeah, but in the beginning he had conduct. So conduct was like somebody under than 18 years old, killing animals, hurting people around him. He can literally injure somebody, and he does not feel empathy for that. Most of these people have a family problem, okay? So when he gets older, he has two paths to choose from. If he is stupid, he will become antisocial. An antisocial person is a person that like to hurt people. Is these people famous for vandalism? Most of them end up in jail, okay? So they are not smart, they are completely stupid, they end up in jail, and yeah, their life goes to misery, but they don't have emotions as well. The psychopaths, however, they are super smart. And because they are smart, they don't go to jail. They can hurt you, do problematic stuff with you, but they will not touch the law. So they will not go to jail, okay? So that's psychopaths. Okay, what is the percentage of psychopaths in our community, guys? I want you to be happy and more motivated. From 1 million people, how many psychopaths do we have? From 1 million people. Put a number. I'm sad to tell you 10,000. It's 1% of the total population. Okay, from 1 million doctors, how many psychopaths do we have? Well, to become a doctor, you need to be smart. You cannot be stupid. So for the medical profession, we tend to have more psychopaths than the other professions. So we don't have 10,000, we have 40,000. If you want to spot that person, it's that ass in your group, in your hospital, doesn't matter, who like to bring everybody down and shine by climbing on other people's back. Okay? So that's how it starts. But like if he has the chance, he will keep escalating it because he does not have emotion. He can smile, he can cry. All of this is bullshit. He does not have emotion. Okay, that's psychopathy. That will be discussed more in psychiatry. Parkinson's disease. The most effective treatment are a non-ergot dopamine agonists. So the dopamine agonists are the best of the best. However, they have their problems, which are usually started in a younger patient. So, and levodopa with carbidopa. We'll discuss this more deeply in a second, which is usually started in older patient. Okay, so deep brain stimulation of the substantia nigra or globus pallidus internus may be helpful in advanced disease, and I also will speak about this. I want to start with them one by one. So they said, first of all, about the dopamine agonist. So the dopamine agonist, we have two types. We have the non-ergot and the ergot. The ergots medication comes from a plants. So ergots, and they tend to have higher toxicity than other medication. So all of the ergots have this shape. They look like wheat, okay? But there is different types of them, of course. They are not wheat exactly, but yeah, they look like it. But all of these, we tend to say the word ergot on them, this type of plant. So the non-ergot, which is the preferred medication, tend to have much less side effects, okay? So the medication examples that you must memorize is rubinerol and bramipaxol. Both of these have increased amount of the dopaminergic activity. So they can lead to nausea, and this is the important one, impulsive control disorder. These people will have gambling. Okay, will start to gamble, be like, after the medication, the story will be about a manic person. He will be like, he will tell you that, his wife will bring him, he will not come. His wife will bring him and tells, my husband has not slept for the previous 6 days, and he's saying that he's preparing for something major. He got a message from a higher power that is telling him that he can change the world. He wrote an article of 450 pages about environmental changes. Okay? All of the stuff I just said, these are symptoms of mania. Okay? So, yeah, he will be manic big time. So you need to tell the patient about this and tell his wife about this before giving the medication. Postural hypotension can occur because of the vasodilatation. Hallucination, that's what the people who told him that he is a prophet to go to the people to tell them that they are mistaken and they should go back to the right path and change the environment and and go do the USMLE and match. They will be confused. They will not sleep at all. They are manic. They can have edema because of the vasodilatation. Ergots like bromocriptine, rarely used due to toxicity. However, it is used in one condition. Let me just put it here. Bromocriptine, it's a dopamine agonist. Dopamine agonist can reduce prolactin, right? Because they can reduce the prolactin, we can use them in cases of a prolactinoma, okay? To reduce the size of the prolactinoma of the anterior pituitary. For that, we use bromocriptine. The next medication is something that is going to increase the dopamine availability. We have amantadine. Oh, nice, amantadine. So amantadine it increases the dopamine release and decreases its uptake, which increases the amount of dopamine inside of your circulation. Mainly used to reduce levodopa-induced dyskinases. And the toxicity will lead to peripheral edema, livedo reticularis, and ataxia. I would like to discuss livedo reticularis because I did see a question about that. Livedo reticularis and amantadine. So basically, livedo reticularis, if you look at the patient legs, they look like this. I like to think about them. They look like a net, right? Or like, you know when you put chicken inside of a cage, the cage look like this, right? So that's livedo reticularis. It like mostly to occur in the legs, lower extremity, as this. And when you see it, you need to think about many things. It can happen only from just cold, people who are cold. It's more common in the white population, and it sucks. It's not painful, by the way. It just happened. It has so many associations, but if somebody has Parkinson, think about amantadine. Okay, the L-DOPA availability. The L-DOPA, this guy, can be converted into dopamine, as you can see. But remember, when you give the L-DOPA, you are going to give it into the peripheral circulation. We have the blood-brain barrier that it must pass through, and then goes to the brain, and then makes the dopamine. And the dopamine is going to work at its postsynaptic cleft. You can see the amantadine here that prevents the reuptake and increases the release, right? And for the L-DOPA to go to the CNS, you need to reduce the peripheral breakdown of the L-DOPA by utilizing carbidopa that inhibits the DDC, and by utilizing the COMT inhibitor like etanocabon and tolcabon, cabon, to inhibit this one, okay? So, increase L-DOPA availability. Agent to prevent the peripheral pre-BBB, before the blood-brain barrier, degradation, increases L-DOPA entering the CNS, which increases the central L-DOPA available for conversion to dopamine. So there will be more L-DOPA to get converted into dopamine. Okay, in the CNS. So we must inhibit this. How to inhibit it? Let's take a look. So L-DOPA available for conversion to dopamine. So we have the levodopa, a carbidopa combination. So the carbidopa will block the peripheral conversion of L-DOPA to dopamine by inhibiting the DOPA decarboxylase, which is this guy. It also reduces the adverse effect of a peripheral L-DOPA conversion into dopamine, like vomiting and nausea. Remember, when you convert to dopamine, a lot of dopamine in the periphery is no fun. It leads to edema. It leads to vasodilatation, which leads to hypotension. Not good. So basically, what you have to do is to block this guy. That means more L-DOPA it will pass the blood-brain barrier. By the way, the dopamine itself cannot pass the blood-brain barrier, only the L-DOPA can. And when it goes to the CNS, it will do its function. So you can see how we use the DOPA decarboxylase inhibitor like carbidopa, to inhibit this. So they are given in combination. Also reduces the adverse effect of a peripheral L-DOPA conversion to dopamine. Etanocabon, entacabon, and tolcapon prevent the peripheral L-DOPA degradation to something known as a 3,0-methyl-DOPA by inhibiting the COMT, used in conjugation with levodopa. So this is a different combination, L-DOPA and COMT inhibitor. So COMT inhibitor, we have etanocabon and tolcapon. Tolcapon is so tall that it reaches your brain as well. So it can inhibit the COMT also in the brain. So the inhibition here and inhibition here will lead to more amount of L-DOPA to be in the circulation. Okay, so more amount of DOPA in the circulation means more dopamine, mean less symptoms of Parkinson's disease. The last thing here is as follows. But before I mention it, I just want to go over a few things here. You can see the carbidopa inhibiting the DDC. You can see the COMT inhibitor like etanacabon and tolcapone inhibiting this. You can see the L-DOPA going to the CNS himself, releasing the dopamine, and you can see how it works at different areas. You can see amantadine and how it blocks the reuptake, increases the release. And you can see how there is the tolcapone also inhibiting the degradation of the dopamine. You can see here the basically the non-ergot and ergot dopamine agonist working directly at the dopamine receptors. Basically, there is many ways to treat Parkinson's disease. However, Parkinson's disease is not an easy disease, meaning it's progressive. So it doesn't matter how many medication you will give. Eventually, they will all fail. After enough time, they will all fail. So what should I do? Like, should I give up? No, you don't give up. So what should you do? Let's see. So they write, curb access, cholinergic activity. So these patients also can be given this cholinergic activity like benztropine and the trihexyphenidyl. Basically, this medication, one momento. Yes, okay. This medication, like benztropine and the trihexyphenidyl, are an antimuscarinic drugs. So they act like basically troponin, right? And they reduce the tremor and they reduce the rigidity, but have a little effect on the bradykinesia, which is basically the discomfort that the patient have from the disease. So they write, try barking my Mercedes-Benz. Okay, so all makes sense. Next thing is carbidopa-levodopa combination. We just spoke about it. The carbidopa inhibits the DCC, meaning it increases the bioavailability of the dopamine in the brain. Unlike dopamine, L-DOPA can cross the blood-brain barrier and is converted by DOPA decarboxylase in the CNS to dopamine. Okay, guys, just a second. Let's take our 10 minutes break and I will... Hello, everyone. Welcome back. In the next, after we finish this today, in the next class, just warning, we'll be starting to do psychiatry. The way I teach psychiatry, that for each situation I give a story. Some of them are politically related, so if you get offended, I'm just telling you, just be careful. I sometimes will put some political personnel because they do actually have the personality problem. That's just a memory hook for you to remember. So just please don't get offended. It's just a way to remember. The next thing. So now we are going to continue about carbidopa-levodopa. So the main function is to increase the dopamine inside of the brain. So unlike dopamine, the L-DOPA can cross the blood-brain barrier. The dopamine himself cannot do that. And after that, in the CNS, when it passes to the CNS, it will be converted from L-DOPA into dopamine. Carbidopa, a peripheral DOPA decarboxylase inhibitor, is given with an L-DOPA to increase the bioavailability of L-DOPA in the brain and limit the peripheral side effect. The clinical use, it can be utilized for Parkinson's disease, it can be used for nausea, hallucination, postural, hypotension, and with a progressive disease, L-DOPA can lead to an on-off phenomenon. With an what is this an on-off phenomena? Basically, the patient, when you give him the medication, his symptoms will improve. But soon after, the medication will start to wear off, okay? Meaning that after some time, the medication will stop working, okay? That's the on-off phenomena. Then impaired motor function during the off period when the patient responds poorly to L-DOPA or medication wears off. Okay. So initially it works, but it's a progressive disease, so it's going to get worse and it will stop working. Selaginine and rasagiline works by inhibiting the MAO. So the MAO-B, which is localized in the CNS, it metabolizes the dopamine, as you can see here, the MAO-B, it metabolizes the dopamine into do-back. So if you don't want do-back to affect you, I hope you know who's do-back, you need to inhibit the MAO, okay? Because you don't want do-back. Who needs do-back? So yeah, selaginine do that. So that increases the dopamine availability. Selaginine selectively inhibits the MAO-B, which is good. It does not work in the periphery and is more commonly found in the brain than in the periphery. Clinical use, adjunctive agent to an L-DOPA in the treatment of Parkinson's disease. The adverse effect, it may enhance the adverse effect of the L-DOPA. Okay, good. So the next thing is going to be a neurodegenerative disease therapy. So we have, first of all, the Alzheimer's disease. And Alzheimer's disease goes something like this. For Alzheimer's disease, you can use donepezil, rivastigmine, and galantamine. After somebody has Alzheimer's disease, how many years does he live approximately, plus or minus, I mean? How many years? Nice, it's 10 years. So what I want you to know, that this disease is progressive. If we say that these are the 10 years, the memory impairment will be like this. So maybe at year number 4 or year number 3, he will be a complete vegetable. All of his brain is gone. So when you give this medication, you are not preventing the death. He will still die within 10 years. But instead of stopping at 3-4 years, you will give him a good 8 years, you know, which is good. So he will have longer period of time with normal memory. Currently, there is a new medication that can function on the amyloid. They are still experimental, but they are showing really great results. So hopefully within our lifetime, actually within this decade, like before 2030, within the next 10 years, we'll see not a cure, but a good treatment for the Alzheimer's disease, so the patient will die with something like this, okay? So let's hope for that. Basically, it's a new medication that functions against the amyloid and help in its destruction. So acetylcholinesterase inhibitor. Okay, so acetylcholinesterase inhibitor, they will basically increase the amount of acetylcholine because the acetylcholinesterase is the enzyme that destroys the acetylcholine. It's the first line of treatment, and the adverse effects include nausea, dizziness, and insomnia. It's contraindicated in patients with cardiac conduction abnormalities because it can promote arrhythmias and death. Memantidine, its function as a NAMDA receptor antagonist, it's relatively new. I mean, the mechanism of action in the book. It helps to prevent excitotoxicity mediated by calcium. Excitotoxicity. I heard about this before. Yes, so excitotoxicity is the thing leading to the neurodegeneration in the brain. It's the thing that is leading to the shrinking of the brain, which can be seen in Alzheimer's disease and also in Huntington disease, okay? So it's because of the excitotoxicity that the brain cells died. So used for a moderate to advanced dementia, the adverse effects include dizziness, confusion, hallucination as well. Okay, good. So the next thing is amyotrophic lateral sclerosis. We have riluzole. Riluzole is a medication that can be used against it. It will increase the survival. This is the good thing. The bad thing that ALS is not curable. So eventually the patient will die. It also decreases the excitotoxicity, which is a way that the neurons gets hyperactive that it just become functionless, okay? So you stimulate it so much it get destroyed. Tetrabenzene, it can be used as well. It's a VMAT inhibitor. What is this VMAT? VMAT is just a form of transporter that help to open up the vesicle, okay? So the VMAT open the vesicles that are full with dopamine. So in that case, if the VMAT is inhibited, they write inhibition of the vesicular monoamino transportase, so vesicular, monoamine, transporter, VMAT, okay? Decreases the dopamine release, dopamine vesicle packaging and release. So they may be used for Huntington chorea and tardive dyskinesia. Okay, good. The next thing is going to be about generalized anesthetics. This is a bit tricky, guys. So I wanna put somebody to sleep. What should I do? Sing for him? No, You should give him an anesthetic. So how to put somebody to sleep? First of all, there is in anesthesiology, you need to do it smart. So how to do that? Well, you bring a smart person, an anesthesiologist, and you tell him to put that person to sleep. First of all, an anesthesiologist, before he put you to sleep, what he will do? The first thing the anesthesiologist should check before putting somebody to sleep. Okay, he checks for allergy. He checks your cardiac function. He checks for your pulse, your ejection fraction of your heart. If it was too low, he will not put you to sleep. Liver function test, electrolyte, CBC, all of the homeostasis in the body, that's the job of the anesthesiologist. I'm a surgeon. I open up a patient and I see the aorta. I'm like, cool, aorta. I cut it, the patient die. During the investigation, who's the first doctor to be asked why this patient died? Is it me, the surgeon? The answer is absolutely not. Is the anesthesiologist the problem? To make the matter worse, I just cut the aorta, killed the patient. I will be like, it's not me, it's the anesthesiologist who did it. He did not give him enough blood, it's not my mistake. I was expecting bleeding, he should as well. So the anesthesiologist's job is really stressful job. Don't get it tricked by the fact that they keep reading a newspaper during the surgery or playing Candy Crush. Their job is really stressful. They must keep focused because if the homeostasis gets messed up, that's all on them. Okay, so their function is to put the person to sleep. Also, to relax their muscles. Also, maintain their homeostasis. Okay? So they need multiple things to be done at the same time. Okay, so CNS drugs. Oh my God, I forgot about then one thing in the previous topic, so I have to go back to it. I forgot to tell you about the last treatment, which is brain stimulation of the substantia nigra pars compacta and the globus pallidus internus. So there is a treatment known as deep brain stimulation in Parkinson's disease. It's cool. You want to see something cool? Take a look at this video. Okay, guys, let's be truthful with each other. Would you like to do a brain surgery on somebody who does not need it? To open his head? Not really. So you will do this if nothing works, okay? Only if nothing works. Look at this lady. Bell rolling tremor, right? So that's really severe. So now she goes to surgery. They implant this thing in her brain, like the electrode in the pars, in the substantia nigra pars compacta. Now this is the after. You can see she's sitting much more fine. Okay, can you please move your hands for me, lady? See, moving the hands without it twitching, without shaking. She is much more stable. She does not have any shakiness of her hand. She can move her extremity well. She had a life-changing procedure, okay? It is a big difference. You might be surprised that we don't do this a lot. I mean, this procedure. Why? Because, as I said before, you don't want to utilize this if other things work. So this is the last thing that you can think about. Like, look at this poor lady, her hand shaking. She's young. And yeah, it's pretty severe. Shaking really bad. Okay, so after all of the shaking will disappear. Yeah, she's fine now. Yeah, she cannot do this. We call it diacokinesia, right? Okay. So basically that's deep brain stimulation, a life-changing procedure. So cranial nerve CNS drugs must be lipid soluble so they can cross the blood-brain barrier or be actively transported into the brain. So drugs with low solubility in the blood have rapid induction and rapid recovery. Why? If they are less blood soluble, what is a blood? Blood is a fluid. So it's another way of saying that it's not water soluble. So if it's not water soluble, that means that it's a lipid soluble. So that will mean that it will pass really quickly to the blood and then really quickly to the brain, right? So rapid induction and recovery times. Why rapid recovery? Because it will not be like in the periphery for a long period of time. Drugs with increased solubility to lipids also have higher potency, which means they are much more stronger. They will knock you out big time at a lower dosages. So there is something called the MAC, which is minimum alveolar concentration. It's only utilized for an inhaled anesthetic. By the way, there is two types of anesthetics. There is the inhaled anesthetics and there is the IV anesthetics, okay? I'm speaking about generalized anesthesia, of course. So when we speak about the MAC, we are only dealing with the inhaled anesthetics. Forget about the IV anesthetics. So it's required to prevent 50% of the subject from moving in response to a noxious stimuli, which is a skin incision. Okay, so it's how much drug I should give the patient for the sake of knocking him out to prevent the pain. And you calculate it as potency of the medication divided by 1 divided by the MAC. Nice. So you can say that the lower amount of medication you give that can lead to the patient not being able to feel this noxious stimuli, which means painful stimuli, the higher potency this medication is. One of the first medication that is utilized as an inhaled anesthetic was nitric oxide. It's highly volatile, okay? But it has low blood and lipid solubility, which means it has a fast induction but low potency, which is nice for the beginning, but not for a long-term type of use, okay? So it sounds good. So I can start the patient on nitric oxide, he go to sleep, and then I can give him another medication for maintenance. So I can use nitric oxide for induction? Yes. Why? Because it has low blood solubility, which means it has rapid induction. But because of his low lipid solubility, that means it has lower potency, right? However, I use Halithone. Halithone has a high lipid and blood solubility. The high blood solubility is not good for me. Why? Because that means it will be really slow. Actually, that's not that bad. That means it will act for a longer period of time. So I can use Halithone for what? What do you think? Halithone. The nitric oxide was used for initiation of the sleep. Why? Because it has a rapid induction and low potency. However, the Halithone has exactly for the surgery itself, because it acts for a longer period of time. And thus, for maintenance, yes. And thus, high potency and slow induction. So we don't care about the induction. We already did it. We just need to keep the patient in the sleep, okay? So now the inhaled anesthetic, there is so many of them. You are not an anesthesiologist. In the USMLE, they don't care so much about the mechanism. They care that you understand that low solubility in the blood means that there will be a rapid induction. That's what they truly care about. So, inhaled anesthetic, we have disfluran, Halothan, enfluran, isofluran, sevofluran, methoxyfluran, and nitric oxide. We have no idea how it works. You are like, wait. Are you saying that the medication we give it to millions of people every single day, we don't know how it works? Yes, we don't. Okay? Actually, there is some theories we are not sure about, so we don't. So, effects. They will lead to myocardial depression. So, if somebody ejection fraction of his heart is 20%, would you like to give such medication? Bad idea. Okay. So, respiratory depression as well, and postoperative nausea and vomiting, and also increase in the cerebral blood flow and intracranial pressure. But they decrease the cerebral metabolic demand. Well, that sounds useful somewhere. Yes, it is. So, for example, if you have a patient that is suffering from Yeah, it could be. So hypoxia of the brain, you can do chemically induced coma. Okay, when you do the chemically induced coma, you keep the patient at sleep. You don't let him to go awake. You will allow more perfusion to his brain, decreasing the cerebral demand, giving him higher chance of surviving after a tragic um, accident. For example, Michael Schumacher. He was driving a car. He got in no, not a car. I don't know. He got in some form of accident. He bled a lot. They put him in chemically induced coma. Why? They wanted to increase the cerebral blood flow, more intracranial pressure, less cerebral demand for giving his brain the best chance of surviving. However, sadly, he did not. He's still in vegetative state. So, adverse effect. Hepatotoxicity for halithone. They love this one. In the United States of America, halithone is illegal to use. Would you like to use halithone? No, you don't. You will go to jail. Don't use halithone. So, in the USMLE, it will be a person who went to Mexico to get surgery. Okay? So, it destroys the liver basically. So, it will be somebody who went to Mexico to get surgery. When he came back from Mexico, his LFTs are high. Okay? Liver function tests are high. And they ask you what's up. You must think that, oh, he went to Mexico, got surgery there. They are still using this in Mexico. That's how you need to think about it. Okay, good. So, yeah, that's halithone. Nephrotoxicity, it can be in methoxyfluorine, a proconvulsant with epilepsy infloran, or they say like epilepsy. Yeah, epileptogenic, exactly. Expansion of a trapped air in the body cavity, like in case of nitric oxide. This can be bad. Why? Because if you give the nitric oxide and it expands the trapped gas in body cavity, for example, in a blip in the lung, what will happen? If a blip or a blip or a bloop, doesn't matter, blip in the lung, will have increased and expansion of the air trapped in it, what will happen? It will burst. It's like boom. And if it will do boom, what will happen to the patient? Pneumothorax. Pneumothorax, spontaneous pneumothorax. Malignant hyperthermia is rare. It's a side effect, but it's rare. It's a life-threatening condition in which an inhaled anesthetic or succinylcholine, I will explain more about this guy. Succinylcholine, by the way, it's a myorelaxant. Remember the job of the anesthesiologist. He do three things. He put the patient to sleep. That's one. After that, he do what? After putting the patient to sleep, he must myorelaxant and watch the homeostasis. Three functions. So, or succinylcholine induce the severe muscle contraction and hyperthermia. Susceptibility is often inherited as an autosomal dominant with a variable penetrance. A mutation is in the renoid receptor, type 1, and it causes an increase in the calcium release from sarcoplasmatic reticulum. Okay, so how to treat such disease? You treat it by the following, by giving dantrolene. Dantrolene is a renoid receptor antagonist, and it's going to help in basically decreasing the release of the calcium from the sarcoplasmatic reticulum, which will lead to less contraction and of the muscles. The contraction of the muscles is so strong, it starts to break down the muscles. The breaking down of the muscles is going to release myoglobin. So in malignant hyperthermia, the severe contraction of the muscles might lead to rhabdomyolysis and kidney injury as well. So please be careful. The next thing is intravenous anesthetic, like thiopental. It facilitates the GABA-A barbiturate, and yeah, it's used for anesthesia induction, short surgical procedure. It decreases the cerebral blood flow and high lipid solubility. The effect terminated by rapid redistribution into the tissue and into the fat. Okay, so thiopental is given IV. It's not like all of these ones that has an is inhaled. But these are different. Thiopental is a barbiturate. We use it for induction of the anesthesia, not for long-term anesthesia. Decreases cerebral blood flow, but has high lipid solubility, meaning it goes to the brain really, really quick. So it's good for induction, not for maintenance. The next thing is midazolam, also known as, what do we call it? Midazolam. I told you about it. My friend had it for his colonoscopy. Yes, exactly. It's a rape drug. So midazolam. It facilitates the GABA benzodiazepine. It's a benzodiazepines and facilitate the GABA by increasing the frequency or the duration of the opening of the channel. What do you think? Is it the frequency or the duration? Okay, that's a mistake. Remember, no, guys. Barabutyrate, duration. It has URA in the name for duration, okay? But benzos, it's the frequency. Benzos for frequency. So, anesthesia, sedation, like endoscopy, and anesthesia induction. It may cause severe post-operative respiratory depression and a decrease in the blood pressure and an anterograde amnesia, meaning after you give the patient the medication, he will forget everything that happens after it. Sounds like a perfect deal for Bill Cosby. So the propofol, it potentiates the GABA, makes it much more stronger, so it can lead you to go to sleep right away. Rapid anesthesia induction for short procedure and also for intensive care unit sedation. So it's something that works quickly. Okay, so I just want to show you propofol because you have seen it before. Propofol. Yes, it has a milky-like substance. I think you have seen it if you attended any surgery. It's really commonly used all over the world. It has this milky substances that is like, ugh, disgusting. Okay, so when the patient gets it, it might lead to respiratory burst and blood pressure. Notice when the anesthesiologist is giving it, his eyes is in the monitor to check the blood pressure, okay? Don't give it quickly. I mean, when you give the needle, don't be just like, psst. No, that's stupid. Slowly. Do it slowly. Otherwise, you will get sued. Why? Because it can lead to rapid respiratory depression. You get yourself apnea and then shit. Okay, guys. All people who have general anesthesia have a tube inside of their lung. Why? Because their respiration will be depressed. In addition, you will give a myorelaxant that will paralyze their muscles so they cannot inspire, expire. So for them not to die, you need to put this intubation tube. Ketamine. Oh yeah. If you have not ever seen somebody in ketamine, you are missing out. Go to the hospital, get some practice, see some ketamine. When you give somebody ketamine, it's an AMDA receptor antagonist. It's pretty cool. It's for a quick procedure, basically. So it's for it's a dissociative anesthesia and it's a sympathomimetic. Let me tell you a little bit about this guy. I will tell you a real life story that will help you to remember about him. I was once working in a hospital in Jerusalem, and there's a guy, little guy. He was like maybe 8 years old. I was working at the emergency department for children. I was training there. Yeah, second year medical student, no nothing, just went there and told them, can you please teach me? And they were like, nice, with me, and they taught me. Okay, anyway, so this child had some type of, I don't know what, I think it's a spider that bited him in his butt and in his buttocks. And when we looked at it, they identified the spider to be like it does not have this systemic toxin, it has just a local toxin. So anyway, there was a really bad abscess in the area, and it must, if you have a bus, what you should do, you should drain it. Yeah. So they wanted to drain it. However, that was big, and the child was small. He must maybe like 8, maybe 10, no, maybe 8. So, and they wanted to drain it. However, the boy looked at it and he just knew about the fact that they are going to drain it, and he was scared as hell, and he has all right to have that. So the guy was like, give him just some ketamine. When they gave him the ketamine, they were cutting it. Does he feel it? The answer is yes, he does. Did he react? No. He was disassociated from the whole situation, meaning that the procedure was happening, but he did not give a single matter about it. Okay? He did not care. It was just happening. He was totally disassociated from it. It did not care. He was speaking, doing everything, but he was not with us, basically. It's pretty nice. Makes you high. It leads to euphoria. Addicts come to you to the emergency department asking, "Oh, my back hurts. Can I get some ketamine, please?" No, you can't. It increases the cerebral blood flow. Emergence reaction possible with disorientation, hallucination, and vivid dreams. Basically, it put you in some other place, some better place where butterflies fly. Okay, let's speak about local anesthetic. Pretty easy mechanism of action. We have the esters and we have the amides. Which one has an eye? It's the amides, so there is an eye. So because the eye is there, we can have them functioning in multiple places. So eyes, if there is one eye here in the drug name, there will be two eyes. If there is no eyes, so I'll play with it like this. 0, 1, 1, 2. So the 0 eyes, 1 eye, 2 eyes. Okay, good. Esters, brokine, tetrakine, benzocaine, chloroquine, kine, 1 eye. So amides has 1 eye, so the drug will have 2 eyes. Lidocaine, mepivacaine, buprovacaine, a lot of 2 eyes, aine, caine. So yeah, basically the medication will, the local anesthetic will go and penetrate the cell, goes inside of the cells and inhibit the sodium channels, but this is important, not from the outside, but from the inside, okay? So local anesthetics go and block the sodium channels from the inside of the cells. So the mechanism, they block the neurotransmission via the binding to the voltage-gated sodium channels of the inner portion of the channel along the nerve fibers. If you remember, the nerve fibers used to look like this. It had the Schwann cells around it, and all over it there was plenty of sodium channels here, and plenty of sodium channels in this area, which is called the nodes of Ranvier. All of these will be inhibited, decreasing the firing of neurotransmitter. So most effective in neurons that fire rapidly because it inhibits the firing. Tertiary amine local anesthetics can penetrate the membranes in an uncharged form, then binds to the ion channels in the charged form. So here it's uncharged, it goes in, and then it can bind to the inside in a charged form. It can be given with a vasoconstrictor. Why would I do that? Well, you give it locally, right? It's a local anesthetic. So you want the medication to stay in the area. You don't want it to go systemically. I mean, if I have a wound here in my arm, if this is my arm, and I have a wound here, I really don't want this lidocaine to go to my heart. If it goes to my heart, it will stop it, you know? So I want it to act locally. Guys, please, please, please be careful about this. I will teach you this, but please be careful. If you understood nothing from today's lesson, just get this point because this can save life. When you have a wound and you want to put this lidocaine injection to numb it, basically, when you put the injection, what to do after you put the injection? What do you think you should do after the injection is in the skin? Aspirate, suck it. Just take some of that thing out. If you see blood here, stop what you are doing. Don't push the medication in. If you push the medication in, you are inside of a vein or an artery, meaning the medication will go straight to the heart, leading to cardiac arrest. You will kill your patient. So when you give a local anesthetic, try to suck. Nothing comes out. Now you push the medication, okay? If you decide to take the needle out and you now want to numb the other side, the same procedure, suck. Blood, don't do it. No blood, do it. Push it in. I hope it makes sense. Always aspirate. If you don't, you might kill your patient. So you use it with the vasoconstrictors like epinephrine to enhance the block duration of action by decreasing systemic absorption. Why? Because basically the epinephrine is a vasoconstrictor which will prevent the systemic flow of the medication. Okay? So the next thing, let's take a look. Thyroid. In infants, in infected tissue, like in really inflamed tissue, the environmental is really acidic. You know, when you go to the dentist, he sees that your gingiva is really inflamed. So he tells you, oh, okay, so take this medication to reduce the inflammation, then come back to me after 3 days. Why he's doing that? Such an asshole. I came to him from far away. Well, no, he's not such an asshole. He's just trying to reduce the pain for you. Because if going to give the local anesthetic for you and your gingiva is really inflamed, will the local anesthetic work good? The answer is not. It will not work good. It will not work effectively, meaning you will feel everything that he does and you are going to be mad at him. So that's why he says, just take this medication and come back in 3 days. Alkaline anesthetics are charged and cannot penetrate the membrane effectively, so you need more anesthetic in that case. Orders how you lose the sensation. You know, when you are in the dentist, he's like, you will feel no pain, but you might feel pressure. Like, okay. Next thing I feel, pain, temperature, and touch. And no pressure. I'm kidding. So the anesthesia work mostly at the pain, then the temperature, then the touch, and finally the pressure. So mostly these two gets lost, but these two stay, okay? Meaning that you can feel that something is happening, but you cannot tell what is it exactly. The pressure is the last to be lost. Clinical use, minor surgical procedure, like for example dental procedure and spinal anesthesia. If allergic to esters, give amides. Adverse effect have CNS excitation, severe cardiovascular toxicity can occur in case of the bupivacaine, and hypertension and hypotension, even both of them actually, and arrhythmia, especially with cocaine and lidocaine. They stop the heart. And remember, please, cocaine is no fun because it can give you a heart attack. And if this heart attack happens, you must follow up the acute coronary artery syndrome protocol, meaning you have to do an angioplasty for it. Benzocaine or brilocaine can lead to methemoglobinemia, in which the hemoglobin will have Fe plus 3, not plus 2. Is the pupil going to be dilated in cocaine? Yes, that's correct. Okay. Benzocaine is most likely given before giving an endoscopy. In the US, similarly, they always give this trick. They do tell you that the person is going to get an endoscope. Before giving the endoscope, the doctors decided to reduce the discomfort of the patient by giving benzocaine as in a liquid form in his throat, so the pain will reduce and the discomfort will reduce while putting in the endoscope. Okay? And after that, the patient is cyanotic, blah, 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 blah. It's methemoglobinemia. Okay? How to treat it? To treat it, you need 2 medication, vitamin C and methylene blue. Okay? Methylene blue and vitamin C. Now, the last thing for today and tomorrow, on Saturday, we'll finish up the CNS and I will start with psychiatry. I hope you are ready for psychiatry. You are going to learn a lot about your family members, your teachers, your classmates, about all of the sick bastards around us. Sorry, not your family. Your classmates, maybe. So, neuromuscular blocking drugs. So, muscle paralysis in surgery or mechanical ventilation. We must paralyze all the body. Why? Guys, this is a guy here. Let's just draw him. I see, just a cutie. That's his diaphragm, that's his legs, and that's his arms. Okay, so that's his abdomen. I'm like, okay, I'm a surgeon. Really good one. So, I'm going to open him up. He's alive, by the way. He's not dead yet. But I want to open him up. If you open him up, what do you think will happen the moment you open him up? His sympathetic nervous system in that area will work, leading to muscle contraction. Exactly. So after you open him up, this will happen. Shit. And you will see all of the intestine, all of the things right here. And yeah, basically you will see plenty of stuff inside of here. But the wound's edges are now so big. So when you decide to close him, if you try to close him like this, will he close with you? The answer is no way. No way. So you are like, you are the surgeon, you are standing here and you're like, anesthesiologist, man, can you please give this guy some myorelaxant? I want to finish my job and go and eat my burrito. And he's like, okay. So he will give him a myorelaxant that will relaxes the wound's edges, okay? So the wound's edges are going to be much more relaxed. And now you can put your stitches in much more easier fashion and go and eat your burrito. So, how does myorelaxant work? Muscle paralysis in surgery or mechanical ventilation. Of course, you don't want to put an intubation tube while the patient can feel his throat and can move his throat because he's going to gag it out. You don't want him to gag. You want to stop that. Selective for the NM nicotinic receptor at the neuromuscular junction, but not at the autonomic NN receptor. So basically, if you remember, we had here NN receptor at the basically the autonomic ganglia, and then we had one more axons coming out that goes to the muscle. This is the muscle, and here they had an M receptor, which is the neuromuscular junction. This one is mediated by acetylcholine. Actually, both of them are. Okay, so it only works here. Is there any medication that works here? The answer is yes. Is the ganglion blocker. You will never learn about them in the USMLE because it's completely illegal to use this medication. They lead to massive hypotension, and the dosage for them is like 0.000000075, something like 20 zeros before the 75. So it's not used. It's actually used in one case. If the patient have a hypertensive emergency and nothing works. We have so many medication for hypertensive emergency. So to use this, you truly have to have no other choice. Okay, anyway, so let's take a look. They write depolarizing and non-depolarizing neuromuscular blocking agent. Let's take a look what it means and what it is. Succinylcholine is a strong acetylcholine receptor agonist, and it produces a sustained depolarization and it prevents muscle contraction. Good. So, reversible of the blockade. So it has two phases when the depolarizing work. Depolarizing sucks. I will tell you why. It has phase 1 and it has phase 2. During phase 1, you have depolarizing of the muscles, meaning it's contracting. During this phase, there is no antidote. Shit. So how to reverse it? You cannot. You are stuck. Okay, block potential by cholinesterase inhibitor. So here's the thing. If you give such medication, you need to keep in mind that for sometimes the patient, you will have zero control over the patient, meaning he can get paralysis and you cannot give the antidote. That sounds dangerous. Yes, that's why we don't like this medication. The phase 2, however, is after like depolarization has finished, now we have repolarization, but it's blocked. The acetylcholine receptors are available, but they are desensitized, meaning that it will not, if you try to use, they are, oh my God. Okay, so we have here the receptor, the NM receptor, of course. Now you have led to depolarization. You will have massive contraction at that moment, and then it's going to be depolarized totally, but the receptor is destroyed, okay? It's desensitized. So that means that if you put more acetylcholine, will it be able to bind here? Can you bind acetylcholine on a destroyed receptor? The answer is impossible. No. So if you cannot do that, can you have contraction of the muscle? The answer is no, not possible. If you cannot contract this muscle, this is myorelaxant. However, you can see the dangers of this. There is the contraction period. Complications include hypercalcemia, hyperkalemia because of the destruction of the muscle cells, because of the contraction, initial contraction, of course, and malignant hyperthermia, which has been seen in the inhaled anesthetics. I told you I will tell you about succinylcholine a little bit later. Here it is. This is succinylcholine. Increased risk for a prolonged muscle paralysis in a patient with a pseudocholinesterase deficiency. There is people who have something in their peripheral blood called pseudocholinesterase. It's just a defect in the blood in which there is an enzyme circulating in there that helps to destroy the acetylcholine. In such patient, the patient will have a prolonged period of time of muscle paralysis. So in patients who have a pseudocholinesterase deficiency, they will have a prolonged phase 1 due to depolarizing neurotransmitter blocking drugs such as succinylcholine. In reality, we don't use succinylcholine at all except in one condition, which is intubation. The only place where we use a succinylcholine is intubation. The reason being, it acts quickly. I mean, it will paralyze the throat and prevent the gag reflux quickly. It just will contract it, and you will be able to put the tube much more easy without this peristalsis movement. Okay, guys, do you know in near the Amazon. We saw it when we were children on, this National Geographic. They have this guy who had this form of a tube, and he had this inside of it like an arrow. And this arrow had poison on it, and the guy was like hunting animal, right? With like, and this just jump, hit the animal, and the animal is like, oh, he cannot move anymore. So what is that? Well, these guys have basically extracted toxins from some trees, and these trees, exactly the curare, has all of them the curare on them. So all of these curare drugs are competitive acetylcholine antagonists. Basically, they did not kill the patient; they just paralyzed it. Yeah. So reversible reversal of the blockade. This guy is cool. Why? Because it is reversible. So you can use something called sugammadex or cholinesterase inhibitor, like neostigmine or hydrophonium, to stop the effect. Okay? Anticholinergic like atropine or gliobrillite are given with cholinesterase inhibitor to prevent the muscarinic effect, like bradycardia. When you give such medication, you might have bradycardia, so you must give something that leads to tachycardia, for example, the atropine. So you get them together. This way, the patient will not have a massive bradycardia. Okay, guys, so that's it for pharmacology for today. On Saturday, we'll speak about more exciting medication, like those that can be treating glaucoma, the opioid, narcotics, spasmolytics, and also we'll be starting with just telling you what we will have to the next class. We'll start psychiatry, we'll speak about conditioning, ego defenses, and we'll speak about grief. And hopefully we'll speak a little bit about child abuse. So see you guys on Saturday. Goodbye, everybody, and good luck.